All right, we have a there you go. All right. Hello, everyone. I warmly welcome you on behalf of IASNM MISSI webinar series. These are monthly webinars. I would like you to mute your phones and devices during the webinar session. The talk will be around 45 to 15 minutes. And after that, we'll have a Q&A session. And with that, I warmly welcome Dr. Shishir Rao. He is a diagnostic interventional radiologist at Mass General and a faculty member at Harvard Medical School. He was previously chief of interventional radiology at Mass General Brigham Wentworth Douglas Hospital. Dr. Rao's interests include interventional oncology, pulmonary and deep vein interventions, and arterial interventions. Along with his brother, Dr. Sishir Rao, he is a co-founder of the Indian Heart Association, a global NGO dedicated to education and screening for cardiovascular disease among South Asians, and was invited by the Government of India to join the Non-Communicable Diagnosed Diseases Workup for 2023 G20 Summit. Without further ado, Dr. Rao.
Hello, thank you so much, Saima, and very honored to be invited to this speaking. I'm gonna be adding my PowerPoint. You can see it now, right?
Yes, we can.
Okay, perfect. So I have a talk. I don't think it'll last 45 minutes, but feel free to ask me questions during the actual presentation or afterwards as well. So I wanted to provide a brief overview in terms of interventional radiology training paradigms, history, as well as scope of procedures that we do in 2025, and then briefly highlight different types of therapies that we participate in, including local regional therapies for hepatocellular carcinoma, METs, renal cell carcinoma, lung tumors, as well as talking about IR interventions for pre-thrombectomy, DVT, and geniculate artery embolization. As you know, IR is very broad, so we'll just have a brief overview of each of these. So IR as a specialty is quite new. It was started in 1963. Charles Dotter, who was an interventional radiologist at the Dotter Institute in Oregon, he did the first procedure on a patient who had claudication in the leg. And even now we call it doddering. He basically used a series of dilators to open up a blood vessel, and the patient actually who had severe claudication could not walk, was able to walk immediately after the procedure. Initially, that was considered a threat to the surgeons. Subsequently, the surgeons who referred him cases would say only diagnose, do not treat on the actual order. The Society of Interventional Radiology was formed in 1983. At that time, it was a Society of Cardiovascular and Interventional Radiology, and it was founded at Mass General. The first issue of JVIR, which is the publication for interventional radiology, was in 1992. And it was originally recognized IR as a subspecialty of radiology in 94 and was provided a primary certificate. It was recognized as a separate specialty within the medical professions in 2012. And in 2016, we had our first residency match in interventional radiology. And in 2022, we graduated our first class. So IR training in 2025. Traditionally, IR training was 1 year. And essentially 5 of the 6 years, year 1 internship, 3 to 4 years of diagnostic radiology, and then a year of interventional radiology used to be the traditional training paradigm. Since we started the residency programs, we now have a surgical internship with IR-focused curriculum, including in ICU rotations and vascular surgery. We have a 3-year diagnostic radiology residency, and then the final 2 years of the residency are focused on interventional radiology, with at least 1,500 procedures to be done and 1,000 in the final year of residency. And as part of this dedicated interventional radiology training paradigm, we have clinical exposure, dedicated longitudinal clinic, as well as time in the SICU and MICU, and then there's board exams, which are both written and oral afterwards. Traditionally, IR was considered a technician. So if a clinician wanted a procedure to be done, they would order it in the computer or in paper form. It would come out through the printer and the IR would have to do the procedure. But really what we're trying to do is convert the profession from a technician to a clinical specialty. So focusing more on behaving like a surgeon, being able to have longitudinal care for our patients, and providing better care for the patients in the hospital and in the outpatient setting. So IR has grown tremendously over the last 10 years, and some of these include imaging tool advancement, improving ultrasound quality, intracardiac echo. So we actually have intravascular ultrasound that we use for creation of TIPS procedures, transcaval biopsies. We have improved fluoroscopy which now has the opportunity to rotate in 360 degrees and reconstruct CT images. We use cone beam CT for arterial mapping. And in terms of treatment, we have new embolic agents, which are better calibrated microspheres or improved microcoils, hotter radioembolization beads, longer microcatheters. We can get to areas that we traditionally have not been able to get to provide more precise treatments, better ablation probes, and there's quite a bit of emphasis now on thrombectomy catheters for DVT and PE. So there's a ton of procedures on the screen, and we don't need to go through all of them, but in terms of arterial procedures, we do a ton of different types of embolizations. They're span from elective type of embolizations to emergent. We do venous interventions, which span everything from cosmetics to deep and superficial venous systems, as well as dialysis work. We do a lot of the bread and butter, which includes lines and biopsies and drainages. We do a variety of GI and GU interventions, including now percutaneous spyglass procedures, which basically is endoscopy into the gallbladder to be able to do lithotripsy, to be able to do basket retrieval, stone treatments. We can do similar treatments in the GU system as well for the kidneys. Quite a few of us get into kyphoplasty, sacroplasty, percutaneous fixation of the bones, neurolysis, pain management procedures, things like cryoablation for bony metastases. So a lot of these procedures are inpatient, but some of these procedures are outpatient as well. And traditionally, IR has not seen patients in clinic, and that's something that's changing. At least half the procedures on the screen, these are patients that we see as a preoperative consult in clinic. We talk with the patient, we meet the family, we go through the risks and benefits, and then after the procedure, we follow them longitudinally, and that's sometimes over the course of years. The vast majority of IR procedures are outpatient type of single-day procedures, so that offers an advantage over surgery. But some of the procedures that require anesthesia include emergent types of bleeders and trauma patients, TIPS procedures who have a high risk of bleeding, as well as certain types of ablation procedures that are microwave ablations, which can be quite painful. So I wanted to have an overview of oncology therapies that IR participates in, focusing on renal cell carcinoma, as well as hepatic therapies. In terms of renal cell carcinoma, urology has been the traditional treatment modality, whether that's surveillance for patients, nephrectomy, partial or total. Radiation oncology could do SBRT. Then interventional radiology has an opportunity to do a variety of ablation procedures, including microwave cryoablation and histotrypsy. Microwave ablation has essentially replaced radiofrequency ablation, which was very commonly performed previously. Typically, lesions that are 3 centimeters or smaller in size are amenable to microwave ablation. The advantage of microwave ablation is it decreases the risk of bleeding through cauterization. It's a very quick procedure. Usually the burn cycle might only be 5 to 10 minutes in order to treat a lesion. Generally, these patients can be discharged from PACU, and it's fairly well tolerated. The disadvantages of microwave ablation, the actual burn cycle tends to be more painful than cryoablation. And then secondly, if you have a central lesion, it has the risk of causing thermal injury to the collecting system or the renal pelvis. Cryoablation is an alternate modality. It's generally preferred to be under 3 centimeters up to 4 centimeters. The advantage of cryo is that you can visualize the ice ball, so it's safe for central tumors. It is fairly painless. It can be done under moderate sedation, and it tends to be CT guided. The disadvantage of cryoablation is there is a risk of bleeding. You're not cauterizing as you're treating. So there is a risk of bleeding, and it tends to take longer time because each ice ball only has a certain maximal size. So you sometimes have to combine multiple probes in order to be able to sculpt an ice ball around the lesion. In terms of evidence-based, urology is the right of first refusal for resection. It's considered the gold standard, but for example, if a patient had a prior nephrectomy or they really want to spare the nephrons, we are an excellent second line of treatment, and we're in the 2016 AUA guidelines as well. So this is a patient who had an RCC under 3 centimeters in the right upper pole kidney. And on the screen right, you can see there's a tumor in the upper pole. It's heterogeneously enhancing. And it appears to be peripheral, so it's not near the central collecting system. So it is pretty low risk in terms of thermal injury. There's no adjacent bowel. So we ended up placing a probe directly through the lesion and decided to do microwave ablation. We did a burn cycle, and you can start to see the gas kind of cavitating within the lesion. Immediately post-ablation, you can see there's gas within it. And then we tend to do a 1 to 3 month follow-up scan and then subsequent interval imaging as well with either CT or MRI renal protocol. You can see that the lesion itself is smaller in size, and that's all eventually would get reabsorbed. This is an example of a renal cryoablation. This is a lesion that is actually a little closer to the renal collecting system, so the decision was made for cryoablation. You can see there's multiple probes that were performed. The advantage of ablation is we can do a biopsy at the same time as we can do the treatment, so we can get a wet read from pathology in terms of whether this is an RCC versus an oncocytoma, and if it is malignant, go ahead and do treatment at the same time. And you can see screen right, this is post-treatment. You can see there's little tracks where the prior needles were, and the lesion itself had an ice ball, and that's kind of disintegrating. This is a more complex lesion. It's closer to 4 centimeters. It's larger in size. And it actually was in proximity to both the peritoneal lining in the bottom left of the image, and it was also in proximity to the colon. So what was done by our team is there was hydrodissection that was done. We take contrast in D5 water, and we hydrodissected the colon away from the kidney. So all the white that you're seeing around the kidney is that contrast material. And then we placed at least 3 probes through the lesion, and you can see the dark circular area, which is the ice ball. Typically for cryoablation, we need to do a freeze, thaw, freeze cycle. So we do a 10-minute freeze, a thaw cycle of 8 minutes, and then another 10-minute freeze. In terms of hepatocellular carcinoma, there's a variety of kind of interdisciplinary modalities to treat, including surgery, resection, or segmentectomies, or ultimately transplant. Radiation oncology is involved, and interventional radiology for a variety of treatments. This is a very busy chart, and we don't need to memorize it, but typically IR is involved in the early to intermediate stage BCLC criteria. Those tend to be lesions that are in the early to medium stage on patients who are not considered surgical candidates. And the treatments that we offer include ablation, which is typically a curative modality, TACE, which is typically not a curative modality, but used for control of disease, and radioembolization, which if a high enough dose of radioembolization techniques are provided, we can actually do a segmentectomy and actually burn the tumor, basically kill the tumor through radiation, and that can actually be curative. So the advantage of these techniques is if we can get the lesions under 3 lesions under 3 centimeters or 1 lesion under 5 centimeters, we can actually potentially be a transplant candidate. So IR therapies in the liver, primary considerations. So typically a lesion under 3 centimeters is most often treated. Microwave is common. It's functionally replaced radiofrequency ablation, but you have to be careful about adjacent structures and potentially causing damage via heat. Cryoablation is more forgiving of heat-sensitive structures, but higher risk of bleeding. And IRE is a newer modality. It's similar indications to cryoablation. It's operator preference, but can be used for high-risk type structures with adjacent heat-sensitive structures. So essentially, if surgical resection is feasible, go for surgery. If surgery is not feasible, then we can consider either microwave or cryo or IRE. So this is a patient who had a peripheral target. In the top left, there's a heterogeneously arterially enhancing lesion in the right hepatic lobe. In the bottom left, you can see it's near the portal vein, but typically not a heat-sensitive structure. So we decided to go with microwave ablation. There's 1 probe that went into it. typically one single burn, and we have a nice radius of treatment around it. So that should have a good effect. This is a central hepatic target. You can see it's actually draped around the hepatic veins and near the IVC and near the heart. So this would be a potentially higher risk case for microablation. So decision was made for cryoablation. You can see multiple probes, 3 probes, and you can see the ice ball form as well, which is that round circle. This is another case along the capsular margin, subcapsular lesion. It was actually near some blood vessels, and you couldn't see it, but near the central biliary system as well. So decision was made for IRE in this case, so multiple probes, and that uses current and was able to kill that lesion. So IR therapies in the liver in terms of catheter directed. So we talked about percutaneous ablation. Other opportunities, so if it's a lesion over 3 centimeters, then catheter-directed treatments include Y90, which is tear, and chemoembolization or bland embolization, which is TACE. If a treatment tends to be, if it's one lesion under 8 centimeters, if it's in a specific segment, we could do a radiation segmentectomy, which is high dose in a small area. If it tends to be more diffuse disease or involving the lobe, we can do a lobar treatment area. In terms of tear, this is something we collaborate closely with our nuclear medicine colleagues. So yttrium-90 beta emitter, and we use typically under 100 micron beads, and we use it for intraarterial treatment of HCC and some intrahepatic mets like colorectal, breast, and others. And the treatment here is driven by radiation rather than ischemia. In the earliest descriptions, until about 5 to 10 years ago, we were using lobar dosing, which is 120 gray of dose to the lobe, but with smaller microcatheters, cone beam CT, we're now trying to go for radiation segmentectomy, which is over 400 gray to achieve complete pathologic necrosis. And traditionally, this was done in 2 parts. We'd have phase 1 to map the tumor. We would use technetium, MAA. We would do a pre-search. We would see what the lung shunt fraction is and see if there's any kind of extrahepatic uptake, and then phase 2 to actually deliver the dose. And in some centers, we're doing it in collaboration with nuclear medicine as a single type of procedure where we actually have the catheter in the area that we want to treat. The patient gets wheeled to nuclear medicine and then comes right back to IR, and then we do the treatment on the same procedural day. And these are some trials in the last few years that showed increased progression-free survival for HCC and other types of mets from Y90. And the legacy trial in 2021 showed that higher radiation dose 400 gray dosing had durability of local response and similar to ablation. So this can actually be a curative measure. It's a busy slide, but a bunch of different trials that showed that Y90 is efficacious and can be used in combination with other treatments for metastatic colorectal cancer, cholangiocarcinoma, and pancreatic mets. In terms of chemo or bland embolization, this is not a radiation type of treatment. It's driven by tissue ischemia. So we tend to use 100 to 300 micron beads, irinotecan sometimes as well, doxorubicin. And Y90 is typically considered a superior therapy, particularly for curative intent, but certain patients eventually reach their maximum radiation dose, or certain patients need repeat therapies. Let's say they have diffuse recurrent metastatic disease, and we want to save Y90 for large singular targets, then chemo or bland embolization can be considered as well. And that can be used in conjunction with chemotherapy. And so this is a patient who had a prior history of HCC and has recurrence along the surgical margin. You can see a heterogeneously enhancing lesion in the right lobe. And then this is a DSA on the screen, right? So you can see 2 vessels that are both leading up to the area of circular blush. And about 10 years ago, we probably would have done a more proximal type of treatment, but now we can do cone beam CTs. So we take the microcatheter to the blood vessel that we think is supplying the majority of the blood flow, and then we essentially create a reconstructive CT scan, and you can see what percentage of the lesion is lighting up. Is there any sort of contrast going into other areas such as the stomach or colon or things like that? And then work with our nuclear medicine colleagues to determine the dose. And we tend to also, after this, do 3-dimensional reconstructions of the liver and of the lesion, and we look at volumes as well when considering dose. And collaboration between nuclear medicine, IR, and oncology is strong. And in my personal experience, it's been with Y90, but in certain centers, there are other types of treatments that are being done. Holmium 166, which can be used for direct visibility for SPECT and MRI and functions similar to Y90 in terms of beta emission. And then also for imaging, it actually has the gamma emitter effect too, and it's paramagnetic. So that's being used in certain places. Certain institutions are doing PET-CT or PET-MRI guided biopsies as well. Early trials for dotatate haven't shown any sort of clinical benefit for intraarterial versus systemic treatment. Systemic is the standard of care, but there are some additional trials being done. Nuclear medicine, as you know, is super exciting in terms of the theranostic side, molecular targeting, diagnostics, and therapy, and we appreciate their help. In terms of additional procedures that we do, PE thrombectomy is an exciting area that we can massively impact morbidity and mortality. Traditionally, for PE thrombectomy, the treatment options prior to the large bore type of catheters, the options include anticoagulation, catheter-directed lysis, or systemic TPA. So if a patient came in with what we consider to be a massive pulmonary embolism, these are patients who are hypotensive, tachycardic, very ill. Typically, they would get systemic TPA. Now we've actually stratified patients between high, intermediate, and low risk for mortality. So high-risk patients are the patients who are massive. Those are the hypotensive patients. Intermediate risk patients are the patients who are symptomatic, but they are hemodynamically stable. So and in those patients, we look at something called the PESI score, which looks at things like age and oncology history, looking at the predicted mortality. Then we also look for either imaging or biomarker evidence of right heart strain. So that's looking at things like troponin, BNP for heart failure signs, looking at cardiac echo to see if there's any wall motion abnormalities. So intermediate high risk are the patients that we often see who have multiple signs of elevated strain as well as hemodynamic stability, but are symptomatic. Those are the patients we often treat, but thrombectomy also has an involvement in high-risk patients or massive thrombectomy after treatment with systemic TPA. This is a patient, 53-year-old, who was dyspneic and came in and had a CTPE, and you can see a fairly large pulmonary embolism involving bilateral main pulmonary arteries, as well as the lobar and segmental side. And based on the risk stratification, their biomarkers and imaging evidence, they were considered to be a high intermediate risk of PE. So what we did was we did a right common femoral vein groin access. We crossed from the right atrium into the right ventricle with a catheter, used a very stiff wire, and eventually got a very large sheath, a 24 French suction thrombectomy catheter over. We measured the pressures in both sides, which were significantly elevated pulmonary pressures. We gave a bolus of heparin and then heparinized throughout the procedure with the goal ACT of 250. And so this is the suction thrombectomy device. It looks like a garden hose. It's very large. And then we basically do multiple passes. We basically go up and down the main pulmonary artery and into the proximal lobar and suck the clot out. And this is the amount of clot that was taken out from one of the lungs on this patient. And based on the appearance of different patients' clot, we can determine how acute or non-acute it looks. If clot tends to look dark and black, that tends to be acute. If it's more yellow or pink looking, it tends to be more chronic clot. Acute clot is easier to take out, and this can be a life-saving intervention. So for PE thrombectomy, we'll look at duration of symptoms. Acute PE is much easier to treat than chronic PE. We look at testing ultrasound of the lower extremities, transthoracic echo, trope, BNP, and lactate. And rarely these are emergent procedures, but on patients who are very high risk, we call them the ECMO team. We get them access because they might need a bypass scenario. And we'll almost never intubate these patients because of acute drop in preload in patients already with right heart strain. In terms of data, traditionally large bore suction thrombectomy systems didn't exist until 2018, so data is still coming out. As of this February, preliminary studies have shown a benefit of large bore suction thrombectomy versus lytic catheters for treatment. There are other trials that are also currently enrolling. This is a study that came out earlier this year, Peerless study, which showed that suction thrombectomy decreased all-cause 30-day readmissions, ICU admission, and duration of stay and clinical deterioration as well. The caveat was there was no significant mortality benefit. However, the bailout for patients who decompensated with catheter-directed thrombolysis was mechanical thrombectomy, so that might have masked a mortality benefit. And if we look at post-procedural ICU utilization, mechanical thrombectomy, nearly 60% didn't require an ICU stay versus 90+% of patients in the catheter-directed thrombolysis needed ICU stay. And there's also a 1 day or so a decreased length of admission. DVT thrombectomy is a similar type of process. So we use a suction catheter instead of a 24 French. We use a smaller catheter, which is 16 French. We often use a clot retrieving basket to retrieve clot from central lower extremity veins, iliofemoral or popliteal. And on an indication side, case by case, the indications currently are central clot burden, iliofemoral or proximal in an active patient who is symptomatic and refractory to anticoagulation, or signs of phlegmatias or oleodolens, which is arterial insufficiency as a result of venous thrombus and significant edema. Typically, we start with a DVT ultrasound and an IVC protocol, venous phase CT of the abdomen and pelvis. And in this patient, you can actually see there's clot from the distal IVC down into the iliac and femoral veins. So we start by getting froglet popliteal access or do a prone patient positioning. So we want to get access to the backside of their knee. And in this patient, we got into the knee and we see a very ratty, thin-looking vessel with some filling defects that's all clot. And we got more proximal images and showed femoral and iliac thrombus as well. And then when we go up into the IVC, you can see just some collaterals and essentially occlusive type of thrombus along the proximal common iliac and some thrombus in the distal IVC as well. So what we take is this clot retriever basket over wire and we pull the clot 2 or 3 times. And essentially clear the clot out using this basket. Repeat runs, so this is a kind of a post-procedural venogram. You can see a significant increase in flow in the extremity. And then we also do pelvic runs and we keep an eye out for May-Thurner anatomy. So that is compression of the left common iliac vein by the overlying right common iliac artery. And if there is evidence of that, we can also do intravascular ultrasound and measure a pressure gradient across it and then decide whether we want to stent that area or not. So in terms of DVT thrombectomy, we look at duration of symptoms. We look at the ultrasound, we look at the CTV, and then decide on heparinizing or whether we want to do intervention. And early DVT studies as far back as 2016 didn't show any benefit for lytic catheters compared to anticoagulation, but more recent studies have shown a significant reduction in post-thrombotic syndrome using mechanical thrombectomy compared to just anticoagulation. But prospective trials are in the pipeline, including the Defiance trial, which compares the 2 arms. The CLOUT registry compared the anticoagulation arm of a prior trial to mechanical thrombectomy arm of CLOUT. And you can see at 12 months, there's a significant reduction in post-thrombotic syndrome. Only about 20% of patients have significant symptoms versus 40% in the non-thrombectomy arms. And that response was durable even after a year. In terms of outpatient treatments that we do, one of the exciting ones that's coming in the pipeline is genicular artery embolization for the knee. So we use 100 to 300 micron embolic spheres, and we use it to prune vessels that are causing knee pain, genicular arteries. The indications are still being assessed, but the treatment options include for hemarthrosis for pre or post knee arthroplasty, as well as patients who have arthritis of the knee, refractory to pain procedures such as steroid injections or geniculate nerve ablations, and in patients who either are not meeting the standard for knee replacement or are not considered good surgical candidates. Contraindications would be patients with significant peripheral arterial disease, because geniculate arteries are used to provide flow to the foot. So if we are pruning those vessels, that could be problematic. Majority of the data is coming from Dr. Akuno in Japan, who's a thought leader in this space. And Genesis trial in 2024 showed a significant improvement. These are a bunch of different different types of scales, visual analog scale or the Womack scale from Canada. And at 2 years out, half the patients had more than a 50% reduction in symptoms, and there's additional prospective trials coming out as well. And this is a busy slide, but you can see in the middle of the slide, a very hyperemic, lots of kind of vascular looking area around the knee. And our goal is not to shut down the blood flow to the knee, but rather to prune some of these vessels. The hyperemia can cause nerve-related pain. And by decreasing some of those hyperemia, we can actually decrease pain as well. And the results on the right, at 2 years, there's substantial 40 to 50% decrease in pain scales for these patients. And at 2 years out, majority of patients had a significant decrease in the Womack scale. This is top left, you can see we did a femoral popliteal angiogram, and the arrows point to these different geniculate arteries. And so this is typically a 2-hour outpatient procedure. The patient walks right in. We go in with some microcatheters, either via ipsilateral side or contralateral side access of the leg. We don't want to cause any injury to the skin or the cutaneous branches of the knee, so we put an ice pack, cold pack on the knee during the procedure. And after the 2 hours are done, recovery period is anywhere from half an hour to 2 hours in IR, and then we discharge them home. In terms of IR in the next decade, a lot of new therapies coming down the pipeline. Some trials are focused on optimizing synergies of local regional therapies along with immunotherapies to look at episcopal effect for HCC and other types of malignancies. Looking at long-term outcomes of pulmonary artery and DVT thrombectomy. We're developing new embolic agents and looking at uses and efficacy of these embolic agents. And MSK embolizations I find very exciting because most of us have family members who have knee pain or shoulder pain, plantar fasciitis, patellar tendonitis, tennis elbow, lateral medial epicondylitis. These are already happening in Japan, so there's a lot of potential there. Histotripsy, which is basically high frequency ultrasound, can be used for cavitating and treating renal and hepatic malignancies. And then also using ketamine for deep sedation for further reduction of the need for anesthesia. The ultimate goal of IR is really to improve our clinical presence and impact on patients. So having a presence in clinic, on the hospital floor surrounding in terms of multidisciplinary conferences and in the community as well. Thank you to IASNM for the invitation and to my colleagues for their collaboration.
Thank you very much, Dr. Rao. This was very insightful talk, and the opportunities and the horizon that IR is offering, and then this is expanding, which is great. Let me see if we have any questions. So there are no questions in the chat box at the moment. I can start with a question that I have. So we work closely as a nuclear medicine division with the IRs regarding Y90 radioembolization. And how is your practice involved with the nuclear medicine there? And what's the workload with the Y90s?
So
And what's the percentage between Y90s and bland embos?
So when I did training, we were predominantly doing Y90s for whole liver or lobar type of Y90s. In the last 3 to 5 years, it's been a lot more focused on segmentectomy. The volumes were about 50-50 traditionally between TACE, bland embolization versus a Y90. And I'd say now it's closer to 75-80% that's Y90 or even potentially higher. We have a close working relationship with our nuclear medicine staff. We have some interdisciplinary conferences with them, and they're very helpful in terms of actual administration of dose and kind of educating us in terms of the radiation aspects of things. So we work closely with them, and they helped us create the one-day type of treatment where we tape the catheter to the thigh of the patient, wheel them over for planar imaging inspect, and then they come right back and we get a phone call, and then we're able to essentially compress a 3-week type of treatment versus a half a day, or like 2/3 of a day. So that's been exciting. But really appreciate all the collaboration efforts that we have with our nuclear medicine colleagues.
Yeah, that's exactly the numbers that we have here at Emory. And actually, Emory was one of the pioneers in starting the same day shunt and treatment. And that
Oh,
happened during COVID.
okay, amazing.
Yeah, so that's wonderful. I see something in the chat box. So Nandu Menon mentioned in Y90 specifically, do you think PET-based dosimetry will meaningfully change patient selection or outcomes compared to current angiographic planning alone?
Uh, that is a great question, and one that I can't say I have experience with pet-based side. I would be curious what your experience is, Seema and Nandu, in terms of that.
We have been doing that PET-based dosimetry, but that has only been in the clinical trials. We have Dr. Sethi and Dr. Brandon who has been involved. I don't think so. Those are in the audience. Dr. T is here. Maybe he might know a little bit about that. But that
Yeah,
has only.
it's still work in progress, right? We don't have a good handle on the dosimetry of the delivered dose because we still go by Bremsstrahlung, and that's not as accurate as PET-based dosimetry. That's possible, but not all centers have the higher end PET cameras to pick up those small positrons that come from these things and can be used for dosimetry. We are working closely with MIM to develop workflows to have the dosimetry information. But as Saima said, it is still in trial work. It is exciting. However, I need to point out that dosimetry for us and dosimetry for radiation oncology is completely different. And IR needs to be careful because lots of times the uptake of that you see on the scan does not directly translate to dose delivered, and there's a wide variation within that area of uptake, with some areas having significantly higher and some areas having significantly lower. And it's not necessarily that the tumor always gets the highest dose. It just depends on how the vascular supply is. And so I think it's going to be a combination of angiographic and dosimetric approaches that would potentially, with prospective studies, pave a way for better targeting of these lesions.
That's great.
Yeah, yeah, and to add on to what Dr. T said, it's very true. We are doing dosimetry using MIM software, but it's still, I think it's not a true dosimetry model. It's still a part of it. In my personal opinion, ever since I've been doing those part of it is still empiric when we are refining on that.
So it
So
sounds like it's emerging type of technology and not as standardized as perhaps the MAA kind of.
different dosing model, like some people like MERD more than at least at Emory. We are most of our IR like to use the MERD model versus the BSA.
I do have a question. You started off well with a good overview about the beginnings of IR and how it's morphed into its independent specialty more recently with the first batch graduating and all that. And I'm curious, with the way things are progressing, how many IR boarded people actually practice radiology in the diagnostic sense, meaning interpreting scans as well as IR work? Do you have any take on that?
So that's a great question, and I think when I applied to IR, when I applied to radiology, I predominantly considered myself as a diagnostic radiologist who enjoyed procedures, and I felt my training was very strong in diagnostics, and that helped me become a better interventional radiologist. In the last few years, when I go to, I'm still on the medical student admissions committee or, residency admissions committees over the years. The folks who are going into IR now are gung-ho IR. They're very procedurally oriented. They're very clinically oriented. Some of them like diagnostics, others of them almost look at diagnostics as a stepping, they just kind of have to deal with it and bear with it. yet the market, a job market doesn't reflect that. So even though these folks are 100% IR focused and they love the training, I believe I've heard something like 80 to 90% of jobs require some element of diagnostic radiology. It could be diagnostic radiology could involve just CTAs or MRAs or vascular ultrasounds, arterial ultrasounds, things like that. But the majority of folks who are coming out into practice are joining either private practice or joining a corporate type of setup. The folks who are going into academics generally tend to have the vast majority of IR or 100% IR. And there are some very large groups. There's some private practice groups that are 50 to 300 people type groups. And they're very subspecialized to the point where they can allow IR to basically, run the full clinical model. But that's been, I think, a rude awakening for some fellows or residents who've graduated looking at the job market where they are expected to read diagnostics. And there is some degree of friction in terms of IR and diagnostics, in terms of if you're a fresh fellow and you want to develop an IR practice, that's going to require a fair amount of time to set up a clinic. It's going to require time to hire the appropriate staff for that clinic, to have time for rounding and things like that. And some practices are supportive, other practices are not supportive of that. So IR traditionally has been looked at as like a money loser, in the sense that in the time it takes to go do a port placement, you could read 5 or 6 MRIs and have multiple times that RVU. But where I think IR is beneficial is the downstream impact. So IR is helpful for keeping the hospital contract. It's a patient-facing service. It's very helpful for groups to have a strong IR presence, similar to mammography or fluoroscopy, or the therapeutic side of nuclear medicine. And also, it leads to a lot of downstream imaging, and the real income in IR comes from the technical revenue. So groups that have been able to build outpatient labs or that type of thing have been very benefited from a strong IR service. So the vast majority are still reading diagnostic.
Yeah, that's an excellent answer. I think you covered a lot of points. I think there's discordance between private practice and academic practices, and the IR trainees need to be made aware of it. And the RVU model needs to be changed, or at least recognized. And as you said, it's the technical fee and the downstream effects of IR services that pay the bill and bring more revenue to the hospital system or the group, and that needs to be accounted for when determining salaries for the IR people. And a lot of residents don't know about these things because we don't talk about these things in the training program. We are focusing solely on the medical knowledge and the clinical skills. And this, I think, I mean, in nuclear medicine too, we are kind of facing similar issues with theranostics, where it takes much more time to, I mean, Saima is our lead theranostics person, and she can vouch for it, how much time consuming all these non-RVU activities are for patient care. And the model, I think, needs to be changed. And you hit the button where you said that it's basically the downstream effects and the technical fee, and the group or the hospital needs to be cognizant of that. Is there any initiative on a professional society basis to recognize these, or how are because the residents are left to manage their contracts on their own, and they kind of feel left to themselves to fend for themselves. So just curious if IR is doing anything like that nuclear medicine can mimic.
So we have a Society of Interventional Radiology, which is quite a strong professional society, and many of our residents are part of that society, and I sit on the practice development committee for that. And we do a lot of workshops with residents and fellows in terms of how to start off as an early career attending, how to develop practices, how to build bridges with other clinical services, including vascular surgery and cardiology, how to integrate kind of the diagnostic versus the IR aspect of things. So still a lot of work to be done, but over the last 5 years, I've been seeing more and more efforts towards that.
Awesome. One last comment I wanted to make before I don't want to hog all the time is, with increasing workload for IR, I also see an increasing risk of a burnout in IR people. And is the IR society, at least acknowledging that and trying to address it?
Yes, so there's another committee called the PIC committee, which I'm also on. So a burnout can be mental burnout as well as physical burnout. IRs often carry 10 or 20 kilogram type of leads. They have exposure to radiation. There's exposure to musculoskeletal issues in the neck and the back. There's long hours. There's the stress of poor outcomes. There is a lot of overnight calls. So there's definitely a real risk of burnout. And some surveys have said 60+% of IR attendings have some degree of burnout out in the community. So it's definitely important. And they're working on some type of toolkits to improve burnout, but it's not going to be a quick fix. It's going to require support from our diagnostic colleagues, from the hospital, from as well as access to non-judgmental kind of mental health care, the opportunity to have adequate sleep and rest between procedures. So I think it's going to be multifactorial.
Awesome. At least there's acknowledgement, so you can start fixing the problem once you acknowledge it. Awesome. Good.
Thank you.
Dr. Kallur here. Shishir, it was a great talk. I have one question for you. This is regarding your ablation of renal tumors. We were taught that if you put a needle there, there is a chance of seedling. So I just saw what is your experience, or you are highly selecting these cases or which are not surgical candidates, and what is the possibility of tumor seedling when you are planning cryoablation of renal tumors?
So that is definitely a risk that we have been taught during residency, medical school, etc. Certain large-scale trials have shown the risk is very low, well under 1%, and in some trials as low as 0.1 or 0.01%. Some of the newer ablation techniques have a tract ablation feature. So not only do we ablate the tumor, but we can actually ablate the tract, but the tract we ablate it at a lower temperature, so we're not actually killing the kidney along the way that we come out. But as the needle is pulled out, we ablate the tract to minimize the risk of seeding. I personally have not had encountered a case of seeding, but it's rarely seen.
Thank you.
Harshad has his hand up. Harshad?
Hi. Hi. Hi, Dr. Rao. Thank you for the excellent presentation. This is Dr. Gulkarni from MAMP Health Theranostic Center in Michigan. So I have a couple of comments and then one question as well. So number one is, I think there was some discussion about PET-based dosimetry. So one of the developments in theranostics and molecular imaging, which we all are excited about, is really the pre-therapeutic dosimetry, which is, for example, you have several PET tracers where you can actually predict what radiation dose that particular tumor is going to get. So we did some initial studies using gallium-68 labeled MAA, which is what we used before the radioembolization. So there's definitely a lot of promise there. Just wanted to kind of put it on record. The second comment is, I think Dr. Kallur is also in the audience. So there is a lot of interest and a lot of development in the, as you alluded to, in the specific localized delivery of theranostics-based treatment, which is intra-arterial. So with the advent of novel radiopharmaceuticals, we'll be able to see a lot more development in kind of just tapping that first pass effect. And then sorry for the long kind of comment and question, but the third was really the question. So I know the trend is different countries, but the neuroradiologist, is that for the brain interventions, is it a different specialty altogether? And because with the intratumoral application of radiopharmaceuticals, is that something which the neurosurgeons would do, or you'd be doing? So thank you.
I know in India, traditionally neurointervention has fallen under interventional radiology. In the US, interventional radiology basically started the subspecialty, but right now it's about a 50-40-10 split between radiology, neurosurgery, and neurology in terms of specialties that perform it. There are specialized neurointerventional fellowships that are 2 to 3 years. So some folks go straight into that after radiology or neurosurgery or neurology residency. And then there are some interventional radiologists who do stroke interventions with a 1-year fellowship or in an apprentice type of model in the community setting because there's such a high need for stroke treatments. But in terms of specifically tumor type of interventions or aneurysms, more complex neurointerventional work, it's traditionally been done by the super specialized neurointerventionalists.
And on the same lines, Shishir, what about stroke work? Is it again among, because I was in a private practice and there we had a strong IR presence and they were very big on stroke work. Actually, a lot of IR trained people would come and do a mini fellowship with us just to get a more strong handle on stroke work.
Yeah, there's a ton of potential there. I personally don't do stroke interventions, but 3 of the 9 of my co-fellows from residency all did mini fellowships and apprentice type of models and are doing stroke work in the community. And originally, there was a 3-hour, then 6-hour guidelines for stroke treatments. Then it got extended to 12 and 24 hours. And we're using CT perfusion and MR perfusion. So there's a lot of exciting developments in the stroke literature, looking at the core, looking at the penumbra, and being able to prevent worsening of infarcts. So a lot of exciting developments there.
Thank you. Let's see. I don't see any more questions in the chat box or any questions from the audience? Hearing none. So thank you so much, Dr. Rao. This was an amazing talk and very insightful. And thank you to all the audience who graced the presence and were present for the webinar. Thank you. I wish you all best. Wishing you a very happy New Year and happy holidays. Thank you. We'll see you next year.
Thank you.
January.
Thank you all. Happy holidays and happy New Year to everybody.